Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Imagine this. You're one of the millions, literally millions worldwide, suffering from chronic migraines.
Yeah.
And it's not just, a bad headache. It's this debilitating neurological thing that can just wipe out days, sometimes weeks of your life.
Absolutely. It affects everything: work, family, just basic functioning.
So many people miss work, they cancel plans, they're just enduring this awful pain and constantly searching, always searching for some relief.
And the frustration is, for a lot of them, the existing treatments, well, they hit dead ends.
Exactly. Either the side effects are too much or the drugs just don't work for them.
It's a huge unmet need.
So if you were in that boat, what wouldn't you do? What lengths would you go to find something, anything that offered even a little bit of hope?
It's a desperate situation for many, and it really drives home why researchers are always looking, sometimes in quite unexpected places.
And that's exactly where we're going today. We are diving into something genuinely fascinating, a new pilot study. It's looking at a class of drugs called glucagon-like peptide-1 receptor agonists.
Okay, that's a bit of a mouthful.
Yeah, let's just call them GLP-1 drugs for this chat, shall we?
Good idea. Much easier, like Liraglutide, perhaps?
Precisely. Drugs people might know from diabetes treatment or, more recently, weight loss.
Right.
But this study explores their potential, surprisingly, as a treatment for chronic migraines.
Which is, yeah, a really intriguing connection. You wouldn't necessarily link those things immediately.
So our mission for this deep dive is to really unpack the details of this pilot study. We'll look at what they found.
And it's her finding.
Dig into how they think it might be working, this proposed mechanism.
Which is quite compelling.
And then think about what this could actually mean for treating migraines down the line. But we also need to be clear about the study's strengths and, really importantly, its limitations.
Absolutely. Got to have the full picture, especially with pilot data.
And our info comes from a recent health news piece that flagged this, but mostly we've gone straight to the source, the scientific paper itself, published in Headache, the Journal of Head and Face Pain.
Good. Always best to go to the original research.
Okay, so let's set the stage. What problem were these researchers trying to tackle?
Well, as you said, migraines are incredibly common. A neurological disorder affecting, nearly 15% of people globally?
Yeah, a huge number. And chronic migraine, that's headaches on 15 or more days a month.
For at least 3 months. Yeah.
That can just devastate someone's daily life, their work, their well-being, everything. It's a massive burden.
Huge. Now, there's also this known link, an association, between obesity and a higher risk of migraine.
Right. But, and this is where it gets really interesting for this study, the researchers were quite explicit. They did not think weight loss was the key thing here.
That's crucial. This wasn't just, another study saying lose weight, feel better. They suspected something else was going on.
So what was their specific aim then?
Their main goal was to see if these GLP-1 drugs, specifically liraglutide in this case, could work as a preventive treatment for migraine. But specifically in a very particular group, patients who had both chronic migraine and obesity. And, critically, people who'd already tried at least 2 other standard preventive treatments and hadn't gotten relief.
So a really difficult to treat group.
Exactly. People who really needed new options.
Yeah.
A high-need population.
Okay, so how did they actually do it? Let's break down the method so everyone can follow along.
Sure. It was a small group to start, a pilot study, remember? 31 participants.
Okay.
26 women, 5 men. All of them had diagnosed chronic migraine and obesity, meaning a body mass index over 30.
Right.
And like we said, this is key. Every single one had tried other preventive meds before, without success.
So they weren't likely to just respond to anything, maybe less prone to a strong placebo effect.
You could argue that yes, they were treatment resistant to some degree.
And the actual intervention, what did they give them?
It was pretty straightforward. They received liraglutide, one of these GLP-1 drugs, as a daily injection for 12 weeks.
Okay, 12 weeks. And did they have to stop their other meds?
No, that's important too. They continued their existing therapies alongside the liraglutide.
Got it. And tracking progress,
Right.
How did they measure if it worked?
They used headache diaries. Standard practice.
Yeah.
Really reliable. Patients tracked their monthly headache days.
Okay.
But they also look beyond just frequency. They use something called the Migraine Disability Assessment Score, or MIDAS.
Right, to see how much migraine was impacting their actual lives.
Exactly. How much it interfered with work, social life, daily activities, and naturally, given the drug, they also track body mass index.
Makes sense. Okay, so the results, you said they were surprising.
They really were. Quite striking, actually. The average number of migraine days per month just plummeted.
How much are we talking?
Well, at the start baseline, the average was around 19.8 days a month. So nearly 20 days. Think about that. Almost 2/3 of the month with migraines.
Wow, that's incredibly tough.
Yeah. After just 12 weeks on Liraglutide, that average dropped to about 10.7 days.
From almost 20 down to under 11.
Exactly. A mean difference of 9.1 fewer migraine days per month. And statistically, that was highly significant.
That's huge. That's not just numbers on a page. That's potentially getting someone's life back. 9 whole days a month.
It really is potentially life-altering.
Yeah.
That's the kind of improvement people are desperately seeking.
And were there, like, super responders, people who did even better?
Yes. The responder rates were very encouraging. Nearly half the group, 15 out of 31, so 48%,
Okay.
had at least a 50% cut in their monthly headache frequency.
Half their headaches gone.
Right. And even more impressive, 7 patients, that's 23%, almost a quarter, saw a 75% reduction.
Yeah.
And then, get this, 1 patient reported 0 migraines during the study period. None at all.
Wow. From chronic migraine to 0 migraines in 12 weeks.
It's the kind of result that really makes you pay attention, doesn't it?
Absolutely. And what about the disability scores, the MIDAS?
Those also significantly decreased. So it wasn't just fewer headaches. The ones they did have were seemingly less impactful on their daily lives, a real reduction in the clinical burden.
Okay, now here's the part I find really fascinating, almost counterintuitive. These GLP-1 drugs are famous now for weight loss, right?
Yes, that's certainly their high-profile use at the moment. And they affect blood sugar too, of course.
But in this study, you said the weight loss wasn't the driver.
That's what the data strongly suggests. Yeah. Participants only had a tiny, statistically non-significant change in their body mass index. It went from an average of 34.0 down to 33.9.
Barely a nudge.
Exactly. And the statistical analysis confirmed it. The reduction in migraine days was independent of this minimal weight change.
So it's not just lose weight, fewer migraines. There's something else happening.
Precisely. That's the critical takeaway. It points towards a different mechanism altogether, separate from the metabolic effects we usually associate with these drugs.
Did anything else influence the results, like age or sex?
They looked at that too. Age, sex, other medications that patients were taking. None of these seemed to significantly affect how much their headache frequency improved.
So it really points towards the drug itself having this specific effect.
It strengthens that argument, yes.
And were there side effects? People often worry about that with new treatments.
There were some. Mild gastrointestinal issues, mostly nausea and constipation, reported by 13 patients, so about 42%.
Okay, fairly common with GLP-1s.
Yes, expected. But importantly, they were reported as mild. They resolved on their own, and nobody stopped the treatment because of them.
That's good news for tolerability, at least in this small group.
It is. Suggests it was manageable for these participants.
Okay, so let's recap. Fewer migraine days significantly, less disability, and crucially, it's not because of weight loss. So the big question is how?
Right. How is this drug doing this?
Let's try and connect the dots. What's the researchers' hypothesis here?
It's a really fascinating idea, and it involves something called intracranial pressure.
Okay, the pressure inside your skull, from the cerebrospinal fluid, the fluid around your brain, and spinal cord.
Exactly that. The researchers noted that chronic migraine shares a lot of features and even risk factors with another condition.
Which is?
It's called idiopathic intracranial hypertension without papilledema, or IIH for short, usually.
Okay, that's another mouthful. So basically, high pressure in the head, but without a specific sign doctors sometimes see in the eyes.
You got it. And the overlaps with chronic migraine are striking. Risk factors like obesity, being female, sleep issues, and they even respond to some of the same treatments.
Like what?
Like the drug topiramate, and even the newer CGRP monoclonal antibodies used for migraine.
Interesting. So these similarities suggest maybe there's a shared underlying issue, possibly related to this fluid pressure.
That's the thinking. And it gets stronger when you consider other evidence. Some studies have shown that just doing a lumbar puncture,
Spinal tap, where they remove some cerebrospinal fluid.
right, even a single one can sometimes give people immediate relief from their migraine.
Wow. So reducing that fluid, reducing that pressure might be key.
It strongly suggests that controlling intracranial pressure could be a really important maybe underappreciated factor in managing migraine.
Okay, so how do the GLP-1 drugs fit into this pressure picture?
This is where it gets really neat. It turns out that the receptors for these GLP-1 drugs, they're actually found in a part of the brain called the choroid plexus.
And the choroid plexus is?
It's basically the brain's cerebrospinal fluid factory. It's the main place where this fluid is produced.
Ah, okay, so the drug targets the fluid factory.
Potentially, yes. Animal studies have shown that GLP-1 drugs can actually reduce intracranial pressure. They seem to do it by inhibiting a specific pump in those choroid plexus cells, a pump that's essential for secreting the fluid. Some studies even suggest they might be better at this than older drugs used for high intracranial pressure.
So it's like the drug is turning down the tap on the fluid production.
That's a great analogy, yeah.
And is there human evidence for this pressure effect?
Yes, there is. A recent randomized trial looked at a different GLP-1 drug, exenatide, in patients who actually had that IIH condition, the high pressure.
Yeah.
And it significantly reduced their intracranial pressure and also improved their headache frequency. So there's clinical data supporting this mechanism in humans too.
Okay, so that's the pressure angle. Is there anything else these drugs might be doing?
Yes, potentially a couple other related things. Animal models of chronic migraine suggest GLP-1 drugs can also reduce the expression of CGRP.
Calcitonin gene-related peptide. That's a huge target in migraine treatment now, isn't it?
Absolutely. It's a key neuropeptide involved in transmitting migraine pain signals. Most new migraine preventives target CGRP or its receptor.
So these drugs might lower the levels of CGRP itself.
That's what the animal data hints at. And they also seem to suppress something called central sensitization in a key brain area, the trigeminal nucleus caudalis.
Central sensitization, that's like the brain's pain alarm system getting stuck on high.
Sort of, yeah. It becomes hypersensitive, amplifying pain signals. These drugs might help dial that back down.
Okay, so let's try to pull this all together. The big picture hypothesis is?
The working theory is that liraglutide acts on the choroid plexus, reducing cerebrospinal fluid production, which lowers intracranial pressure.
Right.
This reduction in pressure might then lead to less release of CGRP and less central sensitization.
Which ultimately results in fewer and less severe migraines.
Exactly. That's the proposed chain of events.
Which raises a really profound question, doesn't it? If this is right, could these GLP-1 drugs be the first migraine treatment that actually prevents CGRP release in the first place?
Rather than just blocking CGRP after it's already been released.
Yeah. Most current treatments work by blocking it or its receptor. This would be acting upstream.
It would be a fundamentally different approach, more proactive, potentially. It's a very exciting possibility.
It really is. A whole new angle. But we always have to come back to the but. This was a pilot study.
Indeed. And with any pilot study, especially one with such exciting results, we have to be rigorous about the limitations.
Okay, let's talk caveats. What are the main ones here?
Well, first, that mechanism involving intracranial pressure. It's still speculative within this study.
Because they didn't actually measure it.
Correct. It's a plausible hypothesis based on other research, but they didn't directly measure intracranial pressure in these 31 participants. So we can't say for sure that's what happened in this group.
Makes sense. What else?
The study design itself, as we said, it was open label, no control group, no randomization.
Meaning no placebo comparison?
Right. So we can't definitively rule out a placebo effect, although you could argue it might be less likely in people who failed other treatments.
Okay.
Or something called regression to the mean, basically. People who are measured when they're at their worst tend to naturally get a bit better over time anyway. Without a control group, it's hard to isolate the drug's specific effect.
Right. Need that comparison.
Another point is the single center and the very specific group of patients.
Only one hospital and only people with obesity and treatment-resistant chronic migraine.
Exactly. So can we generalize these findings to people who aren't obese or people whose migraines respond to standard treatments? We don't know yet.
Fair point. And the duration, 12 weeks isn't that long.
It's relatively short for a chronic condition treatment.
Yeah.
We have no idea about long-term effects. Does the benefit last?
Right.
Do people develop tolerance? Are there side effects with longer use or maybe higher doses?
All unanswered questions.
All unanswered for now. And finally, the small sample size, 31 people.
Limits the statistical power, right?
It does. The results are promising, suggestive, but you really need larger numbers to confirm things more robustly.
Okay, so acknowledging all those limitations, where does this leave us? What needs to happen next?
Well, the researchers are very clear about that. This is just the beginning.
They're calling for more research, obviously.
Definitely. They specifically say future studies should try to actually measure things like intracranial pressure.
To nail down that mechanism.
Exactly. To see if the hypothesis holds up when tested directly.
And bigger trials, presumably?
Absolutely critical. They call for larger, randomized controlled trials. You need that head-to-head comparison, ideally against a placebo, maybe even against other active migraine treatments.
To really prove cause and effect.
Yes, and across a wider range of patients.
And longer follow-up, too.
Crucial. We need studies that track people for much longer than 12 weeks to understand long-term effectiveness and safety.
And maybe look at different doses. Or different patient groups, like non-obese people.
All of the above. This pilot study has basically thrown open a door to a whole new avenue of research. Now the hard work begins to see what's really behind that door.
It really feels like a potential paradigm shift, though, doesn't it? Thinking about pressure in this way.
It certainly adds a significant new dimension to how we think about migraine pathophysiology. It's a testament to how much we're still learning, really.
So let's just quickly recap our deep dive. We've looked at this pilot study showing an existing drug class, these GLP-1 agonists like Liraglutide,
Known for diabetes and weight loss.
showing real, surprising promise for chronic migraine. And fascinatingly, it seems to work independently of weight loss.
Potentially through this novel mechanism involving intracranial pressure.
Yeah, possibly by reducing cerebrospinal fluid production via the choroid plexus, it really reframes how we might approach migraine treatment.
Forces us to look beyond the usual suspects, perhaps.
You know, for so many years, migraine research felt quite focused on certain pathways, certain neurotransmitters like CGRP.
Which has been incredibly fruitful, leading to new treatments.
Absolutely. But this deep dive kind of suggests we might only now be grasping the full, multifaceted complexity of conditions like migraine.
That maybe there are multiple contributing factors and different ways to intervene.
Exactly. And it makes you wonder, what if the solutions to some of our trickiest health problems aren't always about brand new discoveries? What if sometimes it's about rethinking what we already know?
Or repurposing existing tools, existing medications, in completely novel ways based on a deeper understanding of the underlying biology.
Yeah, it just prompts that question. What other surprising connections are just waiting to be found in other areas of medicine, simply by looking at old problems with fresh eyes?
It's definitely something to think about. The potential for finding new uses for old tools is always there.
A thought definitely worth mulling over.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.